Okay, so today we're going to talk about cardiovascular dysfunction. We're going to start with cardiac defects. So we have congenital cardiac defects or acquired cardiac defects. The congenital cardiac defects are those that are present at birth, and the acquired have to do with some sort of disease process that then causes the defect after birth. This is just a review of the circulatory system. So remember that blood goes from the systemic circulation into the right atrium, into the left ventricle, and then it's pumped into the lungs. It comes out of the lungs into the left atrium, goes into the left ventricle, and is pumped through the circulatory system. So when we are looking at defects, we have a defect somewhere in that pathway. So what are we looking for when we're looking for cardiovascular dysfunction? We're really looking at a variety of different things, and some of it is really similar to the adult patient, but we're looking for poor feeding, tachypnea and tachycardia, failure to thrive with poor weight gain, and that's going to be for your infants. The failure to thrive is a characteristic of infants. Activity intolerance, developmental delays, positive prenatal history. So if we know that they had a cardiac defect when they were born, then they still have that cardiac defect, and a positive family history of cardiac disease. So if there's a history, then it's probably going to continue. I think I've mentioned this before, but my whole family, my mom, my dad, my sister, my brother, myself, we all have the same exact heart murmur, which is, it's kind of interesting that my parents both have the same heart murmur, but it's very audible. However, it's completely benign, which is lovely, but that there is definitely a family history involved in having some sort of cardiac defect or cardiac dysfunction. So we're going to go along our assessment lines. Remember, we're going to, and with cardiac dysfunction, we're going to start with inspection. So nutritional status, that's that failure to thrive. Color, what color is the skin? Is there pallor? Is there cyanosis? Chest deformities, that would be due to an enlarged heart. So is there, are they barrel chested? Do they have lumps where you wouldn't expect to find it? Is their chest have a kind of an extended aspect centrally? When we're looking at unusual pulsations, are there thrills? Are there pulsations in the neck that we can see? And then respiratory excursion. If they're working hard to breathe, it might be due to a cardiovascular dysfunction. And then clubbing of the fingers, and that, again, you're familiar with that from your adult assessment, and that's when the fingernail has kind of an arched look to it at the tip. And then when we're going to palpate and percuss, we're looking at the chest, and we're going to feel that chest. We're going to feel for the size of the heart, and here's where we're going to feel for those thrills as well. So if we feel anything there, if we feel any abnormal pulsations on the chest itself, we're going to feel into the abdomen. We're going to look to see if we can see that aortic pulsation as well. We're going to look to see if we can palpate an enlarged liver or an enlarged spleen. And when we look at our peripheral pulses, mainly what we're looking for there is discrepancies. So is our right pulse or left pulse the same? Do we have similar pulses in our extremities, or do we have a slower pulse in our feet and a faster pulse in our hands? Or do we have the right hand is stronger than the left hand? Those types of discrepancies is what we're looking for there. Then we're going to move on to auscultation. And this is pretty standard. So we want to know, do we have tachycardia, bradycardia? Do we have irregular rhythms or regular rhythms? And some of the heart sounds that we're going to listen for are distant sounds or muffled sounds, murmurs, extra sounds, those rubs, like the pericardial rub, things of that nature. So anything abnormal from a sound perspective, we're going to utilize auscultation to determine. So how are we going to diagnose this, or how is the doctor going to diagnose the actual dysfunction that's occurring? So we're going to do some tests. We're going to do an ECG, EKG, which is going to test the electrical activity of the heart. The echocardiogram gives us a visual image of the heart. And then the MRI gives us more detailed image than the echo does. When we move into catheterization, we can utilize it for diagnostic studies, because we can utilize dyes. We can also measure pressure. So we can look at the pressures that are present within the heart in various areas of the heart. And then we can also see the actual blood flow that's occurring. When we're looking to do interventions with cardiac catheterization, this is what you're thinking of when you hear cath lab. So you're going in to have an angioplasty, so have that balloon blown up to open something up. So the interventional cardiac catheterization is going to alter the physiology of the heart to allow for better flow and hopefully solve some of the problems that we have with the dysfunction that's occurring. And then we can do electrophysiology studies as well, where we're going to record the impulses that are occurring in the heart. And we can actually do ablations with these catheters as well, if there are abnormal impulses. Whoa, we're flying ahead. Sorry about that. Okay. So what are you going to do? What do you need to know as a nurse? So for the pre-procedural care, we're going to do a complete nursing assessment. And especially for the pediatric patient, their height and weight is so important so that we can accurately dose the medications. So do your complete head to toe and make sure to get a current, accurate height and weight. Post-procedurally, we're going to take a look at pulses. We want to make sure that the pulses, specifically the pulses below the cath site, are intact and of the same or of a similar strength as they were before. We want to feel the temperature of the extremity, and this is all has to do with the blood flow. We want to make sure that nothing happened to that vessel that we utilized for the catheterization. We're going to check the patient's vital signs. We want to count the heart rate for a full minute anytime a patient has undergone cardiac catheterization. Make sure we are getting that full minute of count, okay? When we are looking at blood pressure, we're looking for signs of hypovolemia. So we want to make sure that the patient isn't hemorrhaging either at the site of the intervention potentially, or where the catheter stopped, or even at the site of where the catheter went in. We're going to check our dressings, just like always. We're going to assess for RETA, because we do have an incision site. So redness, edema, ecchymosis, drainage, approximation. And then we also want to make sure we have adequate fluid intake. Now, immediately post-procedural, the patient will probably remain NPO. So we're going to make sure that our fluids, our IV fluids, are adequate. The patient was NPO before, in addition to having those dyes, which actually act as a diuretic. So there is definitely a risk for dehydration. So we want to make sure that there's adequate fluid intake on these little ones. The blood glucose levels are going to be specifically important with infants, as they have a tough time or I'm sorry, they don't have a tough time, but they're so small, and so their blood glucose levels are so important to maintain, because if they drop, they don't have a lot to begin with, and if they drop, they're going to have a difficult time bringing them back up. And remember, most of their activity is brain activity, right? That brain works off the glucose. So we're going to want to make sure that we're checking the blood glucose levels and ensuring adequate glucose levels for all children, but specifically infants. So congenital heart disease specifically doesn't happen too often, but as you can see, the statistics here, about 8 to 12 every 1,000 live births, in about 2 or 3 cases are symptomatic in the first year of life. This is the major cause of death, the primary cause of death after infant prematurity of babies in their first year of life. And there's more than 35 defects that are very common. So of those 8 to 12 per 1,000, there's about 35 defects that occur over and over and over again. The most common anomaly is that ventricular septal defect. So that has to do with the closing of the various openings that allowed for the fetal circulation. I'm still tripping over my words. Sorry, circulation. There we go. Circulation, fetal circulation. In a lot of these cardiac defects are associated with other anomalies. So our trisomies, there's many different causes. It can be environmental, so something that happens in utero. Mom could have had an infection. It can be used due to drug use. They can be genetic. So there's many different causes that can be associated with the congenital heart disease. So what are we looking at? So we have the circulatory changes that occur at birth. So as we've talked about, fetal circulation, I want to say circulation for some reason, sorry. So the fetal circulation that occurs, that the blood and nutrients come from the placenta, or the oxygen and nutrients come from the placenta, and that blood it bypasses the lungs, right? There's a small amount of blood that goes to the lungs to oxygenate the lung tissue itself, but the oxygen exchange does not occur in the lungs. So we have the foramen ovale and the ductus arteriosus to bypass those lungs. When the umbilical cord is cut, we have a change in blood flow. If you want to visualize this, there's a great figure 42.2, and it gives you the before and the after, so the fetal circulation and the infant circulation. So when we're looking at the problems, we have acyanotic problems and we have cyanotic problems. This is more of an older classification system, as the cyanotic problems might not actually be cyanotic for every child. So we are really, we're going to classify them a little bit different. So you might still hear these terms, which is why it's in here. However, they're not the most up-to-date ways to classify the various congenital heart diseases. So when we're looking at the actual defects, we want to keep in mind that blood will typically flow from a high level of pressure to a low level of pressure, and that's going to take the path of least resistance. So we could have a left to right shunt or a right to left shunt. So better classification is going to be to talk about what is actually happening in that blood. So we might have increased pulmonary blood flow or decreased pulmonary blood flow or an obstruction. And you can see what's going on there. Or we might have a mixed blood flow and mixed issues that go along with that. Sorry. So here's how they fall in together with those acyanotic and cyanotic blood flows. Okay, sorry about that. Live recording doesn't always come without interruptions, but we were talking about acyanotic and cyanotic and the better terms to be utilized. So acyanotic, we're looking at the increase in pulmonary blood flow and obstruction to blood flow from the ventricles. And for the cyanotic, we're looking for a decrease in pulmonary blood flow or the mixed blood flow problems. So when we're looking at the defects with increased pulmonary blood flow, we're looking at this is the causes here. So there's an abnormal connection between the two sides of the heart. There's an increased blood volume on the right side of the heart. There's an increased pulmonary blood flow or decreased systemic blood flow. And then we're going to take a look and see what the actual abnormalities are. So you can see the list here of the abnormalities that are going to cause the increased pulmonary blood flow. And for those who are visual, here's what we're looking at for the actual blood flow. So you can see blood is flowing from the left atrium into the right atrium and from the left ventricle into the right ventricle, which is obviously going to increase the pulmonary blood flow. So when we're looking at obstructive defects, some of the common causes have to do with a narrowing of the actual blood vessel. So the blood vessel exiting the heart, usually the aorta, will be narrowed, which is going to cause a backup of blood. Corrucation of the aorta is narrowing at the arch of the aorta. So it can narrow at the exit, it can narrow at the actual arch, and all of these are going to increase the pressure before the narrowing is going to be increased, and the pressure after is going to be decreased, and they're going to cause a decrease in cardiac output. So we also have aortic stenosis and pulmonary stenosis that fall into these obstructive defects. And here's the visualization for your obstructive defects. So you can see that that we have a narrowing going into the pulmonary artery there. And when we're looking at defects that cause a decrease in pulmonary blood flow, we can have obstructive defects, we can have various multiple defects. So tetralogy of Flow is 4 common defects altogether. The tricuspid atresia is when the tricuspid valve isn't open at all. So these are all going to decrease the amount of blood flow, of pulmonary blood flow. The tetralogy of Flow and the tricuspid atresia are the most common of these types of defects. And we're going to have a drastically increased pressure on the right and decreased pressure on the left side of the heart. So what we see here is we end up seeing desaturated blood into systemic circulation. So we have the oxygenated blood. We don't have enough oxygenated blood or enough blood being oxygenated. So we see that systemic circulation has a lot of deoxygenated blood as well. Box 42.1 through 42.4 gives a really good synopsis of all of these different cardiac defects. Here's another visual of the decreased pulmonary flow. So as you can see, we have blood going from the right atrium to the right ventricle, and from the right ventricle and the left ventricle, we're going out to the system, whereas just a little bit of the blood is going into the the pulmonary blood flow. So when we're looking at our mixed defects, these can get fairly complex. So We have different complex abnormalities, transposition of the great vessels or arteries, and you can see the list here of different mixed cardiac defects. We see significant desaturation, we see pulmonary congestion, and we see a decrease in cardiac output with these mixed defects. So what are we looking at clinically for our congenital heart defects? Essentially, it ends up looking like congestive heart failure. So the heart is not adequately able to pump the blood to where it needs to go, and specifically into the systemic circulation. So in children, it occurs because of structural abnormalities. In adults, we have other causes. And so we want to make sure these are identified and treated early so that there's not significant damage to the heart muscle itself. And with this, we can look at, it can be right or left sided heart failure, whereas in adults, it's typically one or the other. In children, it can be either, and they can be interchanged. So our goals, though, are very similar in children as they are in adults. We want to improve the cardiac function. So how are we going to do that? We're going to use digoxin. And as with any medication for children, we want to make sure that we have the appropriate dose for that child's height and weight. So we want to make sure we're giving them a very specific dose for their height and weight. We're going to use ACE inhibitors, and we're going to use beta blockers. So all of those things together are going to improve the contractility of the heart and improve the heart's ability to move the blood, right? We're going to remove the accumulated fluid and sodium, so diuretics. And of course, we're going to watch our potassium with our diuretics and use the appropriate medication for the child has low potassium. Decreasing cardiac arrhythmias sure that they're not experiencing any cold stress, that we're going to treat any infections, and this is more for children generally, we're going to treat any infection that comes along very rapidly, because the body is going to demand so much more energy if there's an infection present as well. We want to make sure that that child can breathe effectively so that we provide adequate respiratory support. And we might need to sedate the child if they are extremely agitated. We don't want their cardiac demands to be so high, so we might end up having to sedate that child. And we're just going to encourage rest and decrease stimulation of the child so that, again, we can keep that demand on the heart down. And then we want to improve tissue oxygenation. And we're going to do this by utilizing O2, pretty much. We're just going to make sure that we have adequate O2 saturation and that we're supplementing if needed. When we look at congestive heart failure, and especially in children when it has to do with a congenital abnormality, we're going to want to move on surgery pretty quickly. That's going to give us the best outcome for those little ones. So we talked about how we're going to improve the cardiac function with our medications. And we talked about some medications that reduce the afterload, and then the beta blockers as well. So we're going to need to monitor all of these things. And when we're looking at reducing respiratory distress, that's just making sure that there's nothing going on respiratory-wise for this little one. So if they have asthma, making sure that we're controlling it. If they're having secretions and things of that nature, we want to make sure that we're taking care of all of that so that there is no respiratory distress. We want to maintain a great nutritional status for these kiddos because they need all of those vitamins and minerals, and system measures to promote fluid loss. So make sure that we're measuring I's and O's. And again, the diuretics are going to be helpful there, but we want to keep an eye on it because, again, kids are little, so we don't want them to lose too much fluid. Even though they're accumulating it, we need to make sure that it's within the range that's appropriate for them based on their size. And as always, we don't just have the child as our patient, right? We have the entire family. And anytime something like this is going on, it's going to be very stressful for the family. So we want to make sure that we're supporting both the child and the family through this process. When we're looking at hypoxemia, which is going to be a result of some of these congenital heart defects and CHF, we're looking at arterial oxygen, which is less than normal. And we can do that by taking an ART gas, right? We're going to take the arterial blood gases and run them and see what our oxygen is. We're going to see this being manifested with hypoxia, cyanosis, polycythemia, which is an increase in red blood cells, and again, back to that clubbing, which here's a good example of the clubbing. So you can kind of see, you can see it really well on the thumb, how it curves down. And this is a sign of persistent oxygen deprivation. And when we continue with this, we have a couple different ways to determine whether hypoxemia is actually present. So we're gonna do a hyperoxia test, which is when we give the child 100% oxygen, and then we're going to take the PaO2 and determine whether it's within normal limits, and determine whether there is hypoxemia present. If we do have hypoxemia, we're going to try to treat what's going on. So we can give prostaglandins because they are a vasodilator and a smooth muscle relaxer, which when we open up those vessels and allow them to remain open, we're going to get better blood flow going to specifically to the extremities, and in addition, everywhere else throughout the body, to make sure that we are getting adequate oxygen to the various tissues. We can see an acute hypoxemia event, which is going to be the hypercyanotic spells. If we see this, we are going to treat with morphine because it's going to help maintain what the oxygen levels that the child needs. And this is going to be almost an emergent event, which is going to end in surgery for this child. And we're going to place a shunt. One key aspect of a hypercyanotic spell is the child will become extremely agitated. And that's one of the key signs that the child is experiencing a hypercyanotic spell, especially if you're suspecting hypoxemia to begin with. We want to keep these kids well hydrated and avoid any respiratory infections. So the family for these children, again, we're going to want to help them understand exactly what's going on and help them understand how to manage this illness at home. So there's going to be a lot that they need to look out for when they have a child with a cardiac dysfunction. And so we need to make sure that they understand what they're looking for and what to do if something happens. And we also want to give them a realistic expectation for what the child will be going through and what they can expect from surgeries, from invasive procedures, how the child is going to respond to those procedures potentially, and what the effects of the procedures are, and the recovery time. It's just a nice little picture of a mommy holding her baby. She's got this baby in the knee to chest position, which is going to promote adequate oxygenation. So one thing that we want to be aware of as well is the infective endocarditis. So kids with cardiac defects are at an increased risk of endocarditis. Any cardiac defect is at an increased risk. And that's because that tissue is more susceptible to infection, and the blood flow isn't flowing quite as quickly, so that there could be a buildup of bacteria. The common infections are strep, staph, and fungal infections. And this is when the inner lining of the endocardium becomes infected, and it can have drastic effects. So any valvular abnormality is going to require education about to prevent endocarditis. Specifically in dental exams, we want to make sure that these kids are taking their prophylactic antibiotics, because when the hygienist is scraping away at the teeth, they're releasing so much bacteria that the child swallowing that bacteria, there's enough of it that is potentially being released to where it's going to get into their circulation. And where does all that blood go? Right to the heart. So we want to make sure that these kids have their prophylactic antibiotics and are actually taking them. In addition to the valvular abnormalities, kids with recent cardiac surgery or any invasive lines are also at an increased risk of the endocarditis. It is rare, however, it has a 20 to 25% mortality rate if it is or upon diagnosis. So it is very dangerous, and we're going to treat very quickly with high-dose antibiotics. We also are going to take a look at the heart with an echocardiogram and make a determination about whether there was damage to the tissue and potentially replace any valves that were damaged with the endocarditis. Rheumatic fever and rheumatic heart disease are caused by a group A strep. And this is a common bacteria that causes strep throat. And that's the beta hemolytic streptococcal pharyngitis. So there's your strep throat. And this is why it's so important that we seek and obtain quick treatment for strep throat, is to prevent this. So rheumatic heart disease, it's essentially an autoimmune disease. So it's an immunological response to strep throat. There's my lights, but you can still see me. That's okay. So the valve damage will occur in about half the cases of those who have this abnormal immunological response. Dysrhythmias are another type of cardiac dysfunction. And the difference with children and adults is that in children, dysrhythmias can occur with normal hearts. So even if there is no defect, then we might still have a dysrhythmia in a child. Typically adults, there's some sort of damage that has occurred to the heart, whereas in children that isn't necessarily the case. It does often occur, though, with congenital defects. We see it after surgery, and it can be secondary to metabolic and electrolyte imbalances, because remember that heart is driven by action potentials, right? So our sodium-potassium pump is of vital importance, and maintaining those electrolyte balance are really important. These dysrhythmias can range from being self-limiting and resolving on their own to being deadly within minutes. So maintaining electrolyte balance is probably the best preventative measure that we can do here for kids who have no abnormalities. And then for kids who have abnormalities, we just want to be aware of what their abnormality is, and again, educate on what they need to be looking out for. So pulmonary artery hypertension is really poorly understood. It is progressive and eventually becomes fatal. The best treatment is actually a lung transplant, which can save the person's life, and is pretty much the only way to save the person's life. The individual can be on vasodilators, which will really help to extend their life, but eventually this pulmonary artery hypertension will win the battle. So you can see some of the clinical manifestations here, and some of the things that we do to help extend the life of the individual living with pulmonary artery hypertension. Because although a lung transplant will help, that is a huge surgery to go through, and anybody who goes through some sort of transplant is going to be on immunosuppressant therapy for the rest of their lives and have the potential for rejection, and have to be very cognizant of where they're going and who they're talking to, and things of that nature, which it's fabulous that we have these technologies and this ability, but the lung transplant is a challenging transplant to undergo. And speaking of transplants, so a heart transplant is something that we've been doing for many, many years. We are actually getting pretty good at it, and for kids especially. So 87.5% of kids have lived past 1 year with the heart transplants, or who receive heart transplants. So 87.5% of kids who receive heart transplants live past a year, which is a great number. So, and of those that do pass, it's typically due to rejection or infection. So a heart transplant is going to be our last resort, but some of these congenital abnormalities and cardiac dysfunctions are not curable, and they're not surgically repairable. So we do have to provide the child with a new heart. As you can see, the mortality on the waiting list is high, but the effectiveness of the heart transplant is great. And we can do it one of two ways. We can either take out the child's heart and replace it, or we can add the new heart in without replacing. So you leave the child's heart and add the new heart in to achieve whatever goals the child's heart is not achieving. So hypertension is something that children can experience as well. And we have essential hypertension, which is no known cause, and we have secondary hypertension, which we know the cause of. So with the secondary hypertension, if we're able to fix the cause, that's what we're going to do. They do start screening blood pressures routinely in about age 3 for children in their physicals, sometimes earlier at age 2. But it does become part of a routine screening to make sure that there's no hypertension going on. It usually has to do with something structurally that can be fixed, but it's not always. So we will give kids medication, help with lifestyle changes if needed, and then provide education similar to the way we would with adults. If it's something structurally that can be fixed, then the physicians will go in and fix that structural abnormality. So Kawasaki disease is an interesting disease that, again, we don't know a lot about the causes of it, but it can affect children younger than the age of 5, mostly. So it's something that we're looking out for, especially when we have a child who comes in with a fever that Tylenol and other antipyretic agents aren't touching. So if we have a prolonged fever that's unresponsive to medication and there's nothing else that we can think of that's causing that fever, then we're going to look to Kawasaki's disease. We are going to have the best results with early diagnosis and treatment to ensure that we're not having any damage to the heart. So with the Kawasaki's disease, we're going to have an inflammation of all the vessels, essentially. And what happens frequently is that some of the more delicate vessels, like the coronary arteries, will bulge and will get an aneurysm. So they might have a coronary artery aneurysm. And that's the major danger with Kawasaki's disease. It is self-limiting. It will resolve itself. However, we don't know what damage it will cause in the meantime, which is why we want to treat quickly and aggressively. Shock in children is going to be the same as shock in adults. So we're looking at inadequate tissue perfusion, and there's a variety of different causes of shock. We might have hypotension, hypoxia, metabolic acidosis, and then you can see the list of different causes of various shocks. And shock is essentially circulatory failure. Cardiovascular is the perfect time to stop being able to say the word circulatory, right? Anyways, so with shock, we're looking at circulatory failure, and we're going to support the child. So we're going to provide ventilation. We're going to provide fluids because we're trying to increase their fluid volume. And we're going to provide vasopressor support, which all of those things are going to help continue to allow the blood to flow where it needs to go. And the ventilation support is going to make sure that that blood is adequately oxygenated. Anaphylaxis is a specific type of shock that has to do with a response to an allergen, and it can happen fairly quickly. Penicillin is actually the most common, and it usually happens within an hour, but can happen up to 72 hours actually. So the best prevention is best, but if there is some sort of anaphylactic reaction, epinephrine is going to be our friend because we have profuse vasodilation, bronchoconstriction, and increased capillary permeability. So all of our blood is going to our capillaries. Our capillaries are letting it out into our tissues and into our the lymph system and other areas, and then we have a bronchoconstriction. So it's a very serious reaction. So again, we're going to support the circulation and the ventilation. And we're to the end. So when you're looking back at that fetal circulation, I did it. We're going to figure out here. So surgical closure of the ductus arteriosus would result in which of the following? Would it result in the stop? Would it stop the loss of unoxygenated blood to the systemic circulation? Well, we don't want oxygenated blood in systemic circulation, so I hope not. Is it going to decrease the edema in the legs and the feet? So is the problem of the ductus arteriosus that we're having a backup in the heart, or is it a different problem? And are we going to increase the oxygenation of the blood, or are we going to prevent the return of oxygenated blood to the lungs? So the answer is D. We're going to prevent the return of the oxygenated blood to the lungs. And if you go back and look at that figure, I think it was 42.2. Yep, 42.2. You can see why. So remember, the ductus arteriosus allows the blood from the right ventricle to go into systemic circulation as opposed to going to the lungs. So if we have an opening, then we're going to have the oxygenated blood going. Sorry, I lost my train of thought. So if we have an opening, then we're potentially going to have the oxygenated blood going back into the lungs, which we don't want. We want the oxygenated blood going out into the body and the deoxygenated blood going into the lungs. So we're going to prevent that return by closing that gap. So sorry for my tongue tie, and I hope you have a better understanding of cardiac dysfunction. And as always, please feel free to email, text, or call, or stop in office hours with any questions that you have. Have a great day.